Good afternoon, everyone. Welcome to this week's discussion and update on COVID-19 webinar. My name is Kathy Purdy, and I'm a marketing manager at Schoeneck King. Just two quick housekeeping items before we get started. Please enter your questions through the Q&A box located at the bottom of your screen, and we will do our best to address those as time allows. Also, please take a moment to complete the brief survey once the webinar has ended. Your comments and suggestions for future topics are important to our attorneys, and we appreciate your input. So to hand things over, or to kick things off, I'm going to hand it over to Pete Jones.
Thank you, Kathy, and good afternoon, everyone. Thanks for being with us again today. We've got another full program for you today, and we thought we would start with a couple of different presentations on vaccine issues. So first, we're going to start with some of the science and background. We're going to go to Hermes Fernandez. Hermes is in our Albany office, and take it away, Hermes.
Thanks, Pete. Well, I haven't spoken on this panel in a while, and I jumped in because there's actually a chance to deliver some good news. And so here I am. I've been Mr. Gloom and Doom in some of these other presentations. I'm just going to talk about where we are on vaccines in terms of availability, supply, and use. And the reason I really want to do this, apart from being actually able to deliver good news today, is the fact that we started receiving questions in the firm about who's going to be required to take the vaccine? Should people take a vaccine? What's the rules regarding mandates? Well, let's all step back a second before we start to actually talk about mandates and talk about availability and what may be coming down the pike. Even though we are very, very close now to vaccines being available in the United States, we're not quite there. The Pfizer vaccine, which was developed with a European company called BioNTech, is going before the Food and Drug Administration for its advisory panel in 2 days, on the 10th of December. That's an advisory panel which will then make a recommendation to the FDA for emergency use. Emergency use is something that's, as the name implies, it's unusual. Right. Typically, there is a very lengthy multi-year process for drugs to come onto market. What we're seeing here, because of the occurrence of the COVID-19, there's a need for something here and now. And we have circumstances where we are very fortunate that there are some vaccines that have shown such remarkable promise and have shown so few side effects that we're on the verge of using them. The first is this Pfizer-BioNTech vaccine, which actually began distribution today in the United Kingdom, right? Britain has had its first inoculations. It could be, if things go through the FDA process, we will have inoculations next week in the United States. But there is a lot of buts with that whole process. There are questions of distribution. There are questions of supply. For the Pfizer vaccine, you've probably heard this, it needs to be maintained at negative 94 degrees, right? Negative 94, that may be July in Oswego, but most places, that's very, very cold, right? And that creates huge logistical issues. The vaccine itself has to be kept in a case that can only be opened twice a day for no more than 5 minutes. That suggests there's a great chance for spoilage. The United States has purchased in advance 100 million doses from Pfizer. That's really what Operation Warp Speed was. Operation Warp Speed, despite the various rhetoric around it and who delivered the rhetoric, really was the United States government providing money to pharmaceutical companies to speed their research and to support their research. For Pfizer, it was the United States signing a contract to purchase 100 million doses of the vaccine. Now, 100 million doses doesn't mean 100 million people will be able to get the Pfizer vaccine. It means 50 million people will get that Pfizer vaccine, because it takes 2 doses for maximum efficacy. Vaccines can be approved when they are 50% effective, which means that they will reduce the incidence of symptoms in 50% of the people, 50% of the time, right? That's not a large standard. What we are seeing, because this is new technology, literally new technology involving messenger RNA. Don't ask me what messenger RNA is. I don't know. I know it has something to do with spikes. It looks very much like the coronavirus vaccine in widgets, thinking teeth of a gear connecting. That is in some way how this vaccine works. But what we have here is a vaccine that after 2 doses is projected to be 95% effective. That is the gold standard in vaccines. There are very few vaccines that are that effective. The measles vaccine has effectiveness to that level. The polio vaccine that we all forget because it's basically ancient history at this point, had an effectiveness around that type of number. The usual flu vaccine that people receive is something like 50% effective, 55% effective, and it's something that people get on an annual basis. This vaccine, apparently, according to data that was just released today, is expected to be 52% effective if people get 1 dose and 95% effective if people get 2 doses. The 2 doses have to be delivered 21 days apart. Now, let me talk about one of the other issues that we'll see here, which is going to be very significant. And that is after people get the 2nd dose, what the testing shows, and the testing is over 44,000 people, so this is a fairly large sample size. There are side effects that tend to last for up to 1 day following the 2nd dose. And the side effects, my guess is, will cause some people to say, I don't want this vaccine, because it seems that what people will have is 1 day where they feel like they've got the flu. In the age group 16 to 55, more than half the people who take that 2nd dose reported fatigue and headaches. 1/3 reported chills, and over 1/3 reported muscle pain. In age group over 55, the numbers were very similar: half with fatigue, 1/3 with headaches, 1/4 with chills, and 30% with muscle pain. When people get this vaccine, a good number of people are going to need a day off. Because they will feel like they're sick. I'm sure there'll be a number of people who will suggest they've gotten COVID for that period of time, but that is going to be a real issue and will cause people to have some concern about how this is being distributed and how it affects them. So when we have a limited supply, which we have, right, only 100 million doses at this point, when we begin to talk about whether there will be a mandate, we may not get to the question of mandate, because you first have to go through the people who want to take the vaccine, who are willing to take the vaccine. Now, government may set some rules on this as well, but we haven't seen those yet. You know, in many circumstances, there are vaccines that healthcare workers, for example, are required to take, all right, or they cannot work. The flu vaccine happens every year on that basis, but there are others. There's quite a list of vaccines in the state sanitary code that are required for healthcare workers and for others. Think of the vaccines that are required for children to go to school. Think of the vaccines that are required for individuals to go to college. There's over 20 drugs listed, or 20 vaccines that are already in law. We don't have that at this point. That would come from the state. It could come from the governor or his emergency authority, but that emergency authority evaporates at the end of March. Otherwise, it would take a state legislative enactment signed by the governor to have some sort of legally required mandate. But again, we may not get there because we have supply issues. Now, there are a number of other vaccines in the pipeline. Moderna has a vaccine that apparently is structured very similar to the Pfizer vaccine. The federal government has also purchased 100 million doses of the Moderna vaccine, which also requires 2 doses. That gets us up to 100 million people. There's 330 million people in the country. New York at this point has 170,000 doses of the Pfizer vaccine, which is enough for 85,000 people. So at this point, if the FDA were to approve the Pfizer vaccine, we have enough doses for 85,000 people. right? Assuming no spoilage and assuming people show up on the 21st day to get their second dose. So we have a lot of time to figure out questions of who gets the vaccine, when they get the vaccine, whether they will be required to get the vaccine. These are the topics that people are discussing now that require thought and require a plan. But we don't need to be deciding today or tomorrow many of these questions. Now, apart from that, the only other thing that I want to mention in my limited time is that, well, I've mentioned those two companies. There are actually 58 vaccines in clinical trials today in the United States. So the supply can grow, quickly and vastly. There's a process for drug manufacturer for clinical trials. They're called clinical drug trials, and there's phase 1, phase 2, phase 3. There are 13 that are in phase 3, which is the large scale efficacy. So we could see in very short order, in a matter of months, many more vaccines coming in place. Some of them will present other different sorts of issues. The Moderna vaccine is different than the Pfizer vaccine in that the Moderna vaccine might be more easily distributed. It can be distributed at room temperature, right? With a huge difference from -94. Almost all of these are used with messenger RNA, which seems to be an incredible scientific breakthrough and suggests that most vaccines that are developed hereafter will be used based on RNA. They will not be simply a small dose of the disease you're trying to avoid. There's only one drug at this point in clinical trial that is based upon the old standards of for vaccines. So we'll see what becomes of that. That may have fewer side effects in that short term. We don't know how that all will play out. And then, like I said, I had one last point, but this truly is the one last point. There was the question of, I know many people being concerned about Project Warp Speed. And Project Warp Speed, right, was this thought of, is this coming too soon? It's not. It's not coming too soon. This has actually gone through serious scientific efforts. The two vaccines I've been talking to you about today, Pfizer and Moderna, actually started process in January. They began development in January. Project Warp Speed was not even announced till April. And again, Project Warp Speed was simply about putting money behind these projects. The process for the vaccination development and the fact that the vaccination testing is being done more quickly, that process actually began being developed 10 years ago. Not April of this year, but 10 years ago, and we're seeing the benefits of that today. So with that, I think I'm only 2 minutes over. Peter, I can conclude.
Thank you, Hermes. Appreciate that. A lot of interesting information there on the vaccine, and a lot more to come, obviously, as things continue to develop. Okay, we're going to turn it over now to Jessica Moeller. Jessica's in our Garden City office, and although Hermes said, we don't have to answer this question yet, we are getting this question. And I don't know that we're going to have definitive answers, but I think we want to start thinking about the considerations. So Jessica, take it away.
Thanks, Pete. So like Pete just mentioned, we are starting to see a lot more clients and a lot more employers start asking the question of, well, when this vaccine is available, readily available and accessible to me as employer and my employees, what do we do with it? How are we able to utilize it potentially to help protect our workforce and, in some contexts, to also help protect the individuals and the populations that we serve. And, so there's this question that, we're getting asked, can we mandate it? And if so, what do we need to do in order to legally make sure that we don't have any issue with the various laws that could come into play? And, this question, can we mandate our employees to take this vaccine? While it sounds like a simple question that, you may want to think has an easy answer of yes, you can mandate it, or no, you can't mandate it. It actually is a quite complicated question that implicates numerous different laws on the federal level, the state level, the local level. It implicates, a whole host of considerations, not just with regard to, potential discrimination issues or accommodation related issues. It implicates considerations on the bargaining front if your workforce is unionized. That's true both in the public sector and in the private sector. There's likely going to be some bargaining obligations and considerations. So this question of can we mandate the vaccine is, quite complicated. And it's compounded by the fact that there's still so many unknowns with regard to the vaccine itself, and also how the law is ultimately going to treat this newly developed science and newly developed vaccine. And so, we obviously have not yet had any court rule on the issue of, can I as employer mandate my employees to take this COVID vaccine? So we're left with a position of, needing to sort of look at what has happened in the past with other types of vaccines and other situations that are, as most analogous to this situation as we can, to try and, make some best guesses or, educated, guesses on what the court may or may not do with whatever comes down the line in terms of mandating this vaccine. So, when we take that approach, we look to the past. What kinds of vaccines have previously been mandated? And the very first thing that comes to my mind, and I'm sure comes to many of your minds, is the annual flu vaccine. There is a body of case law and body of legal analysis that has already developed with regard to the flu vaccine and whether that vaccine can be mandated for employees. So there are some lessons, I'll say, that we can, start to take from how the courts have viewed the flu vaccine that may be applicable in the context of the COVID vaccine going forward. And so what are those lessons? And the first lesson, sort of the threshold issue that we can take from those, flu vaccine scenarios and body of case law is, why are we doing this? Why are we mandating, a flu vaccine for our employees? And, generally speaking, these types of mandates, the policies that are built on these mandates, are premised with the general understanding that mandating a flu vaccine for our employees is necessary or appropriate to achieve protecting the health and welfare, health and well-being, health and safety of a population, whether it be the population of employees or those that we serve. And, not surprisingly, this is very common in the healthcare context. And so, it's not uncommon for a healthcare employer to mandate its workers to get the annual flu vaccine. Now, excuse me, whether we can, in the flu context, make that type of general understanding or base our policy on that general understanding, it is also, at least as of now, and based on the current case law, it really has been looked at in the healthcare context. And the cases that have developed with regard to mandating the flu vaccine really have been limited to the healthcare context. And so one question that comes to my mind immediately is, if we look at these types of lessons that I'll with regard to the flu vaccine, and I'll talk about some additional lessons. But if we look at these lessons from the flu vaccine as potentially being analogous to the COVID vaccine, one question that immediately comes to mind is, well, if the flu vaccine case law really has been developed within the healthcare context, can we jump now outside of that context with regard to this new COVID vaccine? Or are we really going to be more limited in potentially, having a mandate really within the healthcare context itself? So that's one question that comes to mind, and I'm raising these considerations really for your information and thought. I don't have an answer for you on that particular question, whether we'll be able to do this type of potential mandate outside of that healthcare context. So jumping back to lessons from the flu vaccine, another thing that we have learned and that's developed with the case law is in order to have a lawful mandated policy for the flu vaccine, there needs to be certain exceptions built in. And those exceptions really come from Title VII of the Civil Rights Act, which lawfully requires employers to provide accommodation for individuals who have sincerely held religious beliefs. So the other law that comes into play is the ADA, Americans with Disabilities Act, that requires employers to provide reasonable accommodation to individuals with disabilities, absent, undue hardship. Another law that comes into play is the, excuse me, the Pregnancy Discrimination Act, which similarly requires accommodations to be made for individuals due to pregnancy. Now, these three laws, I named the laws at the federal level, but of course there are essentially equivalent type considerations on the state and local levels as well. But these laws require employers to make accommodations for certain types of certain types of categories. Now, when you apply this to the vaccine context, and as has been applied in the flu vaccine context, what we see is policies that mandate the flu vaccine for employees need to have built into them exceptions for employees who object to getting that vaccine for religious bases, based on their sincerely held religious beliefs, or who, because of a disabling condition, a medical condition, have an objection to getting the vaccine. And so we, as an employer, would have an obligation to accommodate those medically based objections. Similar objections being asserted by pregnant employees. Also, we may have that obligation to accommodate those objections where it's based on pregnancy. And so in order to have a lawful policy, a defensible policy that mandates a flu vaccine, there needs to be built in exceptions for individuals who fit within those different categories that I mentioned. The EEOC has said the key to any type of mandated vaccine policy with regard to the flu vaccine is really the accommodation that is allowed within the policy. So the policies need to have these exceptions sort of built into it to potentially now withstand a legal challenge. Now, we can't just have those exceptions written into the policy and apply something else. So of course, if we have an exception written into the policy, we would also need to ensure that those exceptions are then appropriately applied and granted in the appropriate circumstances. So that's another of these sort of lessons learned from the flu vaccine context. Now, one of the other potential complicating factors is what qualifies as a religion that would need to be accommodated under Title VII and the different state and local laws. A lot of us, I'm sure, immediately think of the very traditional, established religious institutions as the religion that would need to be accommodated. But the law does not define religion as being that narrow, as narrowly constrained to just the traditional religious institutions. And there actually have been cases that have expanded the definition of what is a religion for Title VII and under the law to apply to things like Alcoholics Anonymous, to apply to another institution, another set of beliefs called Onion Head. I don't know how many of you are familiar with that. I have to admit, I needed to Google it to really understand, what Onion Head was. But when you look at it, Onion Head has nothing to do with an established traditional religion. It is a belief of individual health and well-being, emotional well-being, happiness and emotional well-being is sort of the best way to summarize their mission. And something like that could be viewed, and actually a court in 2016 did hold that Onion Head, this belief of one's emotional well-being, was in fact a religion for purposes of Title VII. And so, we may have a religious exemption built into our vaccine policy, but we would need to be open-minded in how we would apply that exception to things other than, what we think of as sort of the traditional religious institutions. So that's yet another potential complication or consideration, as we look at this issue of whether we can potentially mandate a vaccine. And so, these are some of the lessons learned from the flu vaccine context. But of course, the flu vaccine is not the COVID vaccine. The COVID vaccine is brand new science. It is something that is, has a lot of unknowns. And so there's a question of whether the court and whether the law will apply the same type of analysis to the COVID vaccine as is applied or has been applied to the flu vaccine. Will they do it? Potentially. But it's not yet definitively clear. Or will there be additional considerations that employers will have to look at in addition to those lessons learned from the flu vaccine context in crafting, policies or deciding whether or not to mandate a COVID vaccine? And some of those other considerations that, quite frankly, don't seem to come up all that often in the flu vaccine context is, what has our history been like in dealing with this type of illness? It almost sort of is a given in the healthcare context, particularly, that the flu could adversely impact the health and safety of the population of patients that are cared for. And so it sort of goes with, as a given. But what if we are not serving a population? What if the only individuals that we're looking to, protect the health of are our employees? Is that going to make a difference? If we're only looking at employees as opposed to the population that we're serving, will that make a difference? Perhaps. We don't know that answer yet. Another of these sort of unknowns I alluded to earlier is, will the ability for us to mandate a COVID vaccine extend outside of the healthcare context? So if I'm an office-based company, has nothing to do with healthcare, for example, I'm just sort of using this as a hypothetical, will I as employer be able to mandate the COVID vaccine for my employees? Potentially. We don't yet have a clear answer to that. Another, issue and consideration that we will have to inevitably deal with, particularly for those employers who have at least, a population or a portion of their employee population unionized, is how do we handle the bargaining obligation of mandating a vaccine for COVID? So, we all know that where we have a union and represented employees, the general rule is you need to negotiate the terms and conditions of those, the terms and condition of the employment of those unionized employees. And so are we changing a term and condition of employment if we are saying, in order to be employed with us, you must be vaccinated for COVID? You're likely going to have a situation where you're going to need to bargain whether you can impose that type of obligation. There are other potential issues that also come up with, what if we have an employee who refuses to get the vaccine? What do we do with that? If we've decided, after all of the analysis, talking about all the different options with our counsel, of course, and if you as company have decided that you are going to move forward and mandate the vaccine, well, what do you do with an employee who chooses not to get that vaccine despite the mandate? How do you deal with that type of refusal? Do you terminate? Do you discipline for misconduct, for failure to abide by a policy? That's a potential issue. Or do you provide a leave of absence for an employee who doesn't get the vaccine? Do you provide alternatives to employees who choose not to get the vaccine? Potentially, for example, are you able to provide, as an alternative to the vaccine, are you able to provide, the high level of PPE in the N95 mask for an employee? Does that serve the same goal as a COVID vaccine would? When that individual is in the workplace, wearing an N95 mask, from moment of coming into the workplace to moment of leaving the workplace, is that a potential alternative to either, discipline or termination, or potentially even to imposing a mandate for the vaccine? And, what do you do with the employees who have a lawful protected objection for getting the vaccine, religious, medical, pregnancy-based types objections? How do you handle those employees? If you have this generalized mandate for the vaccine with the exceptions built in, as likely are going to be needed to be built in, how do you handle those employees? Do you provide additional accommodation of no vaccine and additional PPE, or some other type of accommodation for those employees? So there's a lot to still sort of be considered, a lot of questions that still need to be answered before anybody really should be making that determination of whether we are going to mandate or not the vaccine for our employees. And so, you know, of course, it's a complicated issue. As you know, I mentioned at the outset, we would of course recommend that you review all of the different options, the potential risks associated with each of the different options, and you know, how best to implement this, you know, within your workplace with your employees. You know, talk to counsel and see what makes the most sense for your particular circumstance. So Pete, with that, I am going to turn it back over to you.
Jessica, thanks. A lot of information there, and I think we will drill down on each of these things as time goes on. As Hermes says, right now, I mean, there are just simply not enough vaccines for this to be an imminent issue, but advanced planning certainly makes a lot of sense, so that we've got these things resolved in our minds when it is time to make those decisions. So let's shift gears a little bit. We're going to go to Aaron Torsello. Aaron's going to talk a little bit about reasonable accommodations. We're seeing a lot of this. It's kind of a review. It's stuff we've talked about before, and yet it's really critical as we proceed. So Aaron, take it away.
Thanks, Pete. And yeah, as Pete introduced, we thought it would be helpful to do another review of the reasonable accommodation issues that we're seeing with relation to the ongoing COVID pandemic. Jessica mentioned throughout her presentation the obligation to reasonably accommodate in a number of contexts. The focus on this abbreviated summary is really on accommodating disabilities within the physical workplace, as your employees are either returning back to the workplace or if they've been in the workplace. And many of us are seeing, I'm situated in Buffalo in Erie County. We're in an orange zone, probably should be in a red zone, but as the numbers across the state are increasing, so is the impact of the COVID pandemic on employees in the physical workspace. You know, it's like I said, especially for employers who have begun to bring employees back into the workplace to the extent they weren't essential from the beginning. You may now be seeing requests from employees to accommodate various medical conditions. So I want to first just start with a very broad overview of what our obligations are. And as Jessica mentioned, under both federal and state law, employers have an obligation to accommodate disabled employees and applicants who can, with or without a reasonable accommodation, perform the essential functions of their job. Who is a disabled employee or applicant is defined by either the federal or state law that applies. Under the ADA, the Americans with Disabilities Act, a disability is defined as a physical or mental impairment that substantially impacts or limits a major life activity. Under the New York Human Rights Law, the definition of disability is much broader than that, and there doesn't have to be a showing that a medical condition has to substantially limit a major life activity. So if you have an employee who indicates that they have a medical condition which either makes them more vulnerable to COVID, or which may be heightened or impacted by the ongoing COVID pandemic, and we'll talk very quickly about what that might mean, you may have an obligation to accommodate that employee. So to begin with, the EEOC has said that there are certain individuals who are, because of underlying health conditions, may be more vulnerable to a poor outcome if they contract COVID-19. And the CDC and the EEOC has referred to the CDC throughout its guidance as a place to go to kind of determine or decipher who might be vulnerable or what types of medical conditions might put someone at higher risk. This list has actually evolved. So the last time I did this presentation was back in the summer, and the list of medical conditions which put somebody in the high risk category has actually changed in that time. So be aware that what we knew back in March or April or even in June is continuing to evolve. So the CDC now has two sets of health conditions, of medical conditions, and one category is conditions that put someone at high risk. The secondary category are health conditions that may put someone at a higher risk or more vulnerable to a negative outcome due to COVID-19 if the person contracts COVID-19. So as a quick summary of some of the health conditions that the CDC has said do put an individual at a higher risk to COVID, COPD, serious heart conditions such as heart failure or coronary artery disease, obesity and severe obesity, type 2 diabetes, cancer, chronic kidney disease, and sickle cell disease. Back in June, just as an example, on this list was asthma. Sickle cell did not appear on this list. They've also separated out type 2 diabetes and type 1 diabetes. So asthma and type 1 diabetes are identified as health conditions that may put somebody at a higher risk. So if you have an employee who comes to you and says, I have this health condition that puts me at a higher risk for a negative outcome should I contract COVID in the workplace, they may ask for an accommodation for that health condition. And at that point, we have an obligation to engage in the interactive process. That is a very formal word for you have to begin to have a conversation with that employee about what accommodations may be available. It may require further conversation with that person's medical professional to determine whether or not or to what extent they really are at risk should they be exposed to COVID. There may be a request for a leave of absence. We don't have an obligation to provide someone their preferred accommodation, but we do have an obligation to provide an accommodation that is effective. So during the interactive process, you have a conversation with the employee, which may involve obtaining additional information from the employee's medical care professional about the risk posed and possible accommodations which may mitigate the risk. Some of those types of accommodations could be, like I mentioned, a leave of absence. It could be a telework situation. It could be increased PPE. There are a number of possible accommodations that are out there. And so long as it's effective, there's not an obligation that you provide the preferred accommodation. But in order to determine whether or not it's effective, again, it's got to be a conversation with the employee and probably with input from the medical care provider. The other situation that we're seeing in terms of accommodations are individuals who have an underlying mental health condition such as anxiety, obsessive compulsive disorder, perhaps depression, things that, mental health impairments that may be impacted or heightened by the COVID pandemic, especially as we are seeing rising numbers across upstate New York. So for many employers here in upstate, we may not have had to deal with this back in April or May when the pandemic started, but with employees in the workplace now, as numbers are increasing, people are maybe getting more anxious. If they have an underlying diagnosed mental health condition, which is exaggerated or increased or triggered by a COVID-related reason, we may have an obligation to accommodate that employee's mental health condition. And you would go through the same analysis, that same interactive process with that employee to determine what accommodations may be available, what is the preferred accommodation versus what might be effective. If we, depending on what the request is, you will have to analyze whether or not that accommodation is reasonable or whether or not it provides an undue hardship. Within the context of a pandemic, the EEOC has also issued guidance on the undue hardship analysis, and has indicated that the undue hardship analysis within the pandemic context may be a little bit different than what we're dealing with outside of a pandemic. So within a pandemic, an employer, has said that it may be more difficult to conduct a needs assessment for the employee. They've indicated that it may be more difficult to provide a temporary assignment. They've indicated and acknowledged that it might be more difficult to remove certain functions, especially if there are a number of people missing from the workplace. So the EEOC has taken into account in its guidance in the pandemic context that the undue hardship analysis might change. So if you do have an employee, and I'm not talking about the vaccine accommodations in this particular segment because that impacts a whole other host of issues. But if you do have an employee who's seeking a reasonable accommodation for COVID-related reasons, either because of an underlying physical or mental health condition, remember you may have an obligation to accommodate. You need to engage in the interactive process. Be sure to document whatever you do and decisions that are ultimately made, especially if you don't provide the accommodation that's requested. And it's usually really helpful to reach out and engage your outside counselor, your outside legal counsel, to ensure you're following all the right steps. And with that, Pete, I will throw it back to you.
Thanks, Erin. Again, a lot of questions here in the Q&A. Best advice I think we can give to you is that you need to analyze these things on a case-by-case basis. You need to look through it. You need to apply the principles that Erin's talking about, and it's hard to say yes or no to particular obligation questions unless you do that analysis. Okay, so we're going to turn now to Katie Anderson. We are a little bit over time, but I think it's worthwhile to do the update from Albany. So Katie, please update us.
You got it. There's always lots happening out of Albany, so I'll make it as brief as I can. Biggest updates from yesterday. Yesterday, the governor announced that there's going to be changes with indoor dining. First part is if in the next 5 days a region's hospitalization rate does not stabilize, then it depends on what region you're in. In New York City, means that indoor dining will close. Everywhere else, the capacity for indoor dining will be reduced to 25%. This is to follow CDC guidelines that came out on Friday about indoor dining and about hospitalization rates. What will remain to be seen, the CDC has changed other guidance recently. New York has yet to update its guidance to reflect those changes, namely the quarantine, the 10-day quarantine out of the CDC versus New York's still 14-day quarantine. That's going to be a really big thing that, of course, we will be watching out for. It is largely expected for New York City, at least, that New York City indoor dining will be closed on Monday. The governor said in his presentation yesterday that this would take effect, that it wouldn't be on the 5th day everything has to close. It would be a few days out. But there's nothing written at this point. There's no executive order that's been issued after this press conference yesterday. There's no official guidance document that's been issued after this press conference yesterday. So a lot of this stuff is really subject to change until we have the written document. Looking at this Surge and Flex program, yesterday also marked the beginning of the governor's Surge and Flex program that was discussed last week. The biggest thing about that is that hospitals must expand bed capacity by 25%. We we'll be watching that closely as well. Another big change from yesterday too, another way that a region can become a red zone is if that region reaches critical hospital capacity. So this is going to be a pretty complicated way to look at things. So I will break it down as best as I can, but without some more firm guidance from the state, these things are likely to change. And without more firm numbers from the state, this is going to be a hard thing to look at. It's really, my brain constantly feels like there's lots of things spinning in it. And this one is one of those things that really makes me spin around. First thing is this will take effect after the implemented surge and flex that was implemented yesterday. So it's in effect based on that press conference, but we haven't seen, again, no executive order has been issued about this. What does it mean? If a region's 7-day hospitalization growth rate shows that the region will reach a 90% capacity of their hospital limit within 3 weeks, that region goes to a red zone. So we don't have at this point that growth rate number for each region. We do have, though, numbers about what the percent available of hospital beds, and we also have the percent available of ICU beds. It's not the rate, but it's a good indicator to show where things may be going. Again, it's not these are not the exact numbers that the governor's office is looking at for this, but it's the closest we've got. The biggest, obviously the big concern that the governor's been talking about has been Finger Lakes and Western New York. You look at that COVID hospitalization as a percent of the region's population. Both of them have the highest. But you're looking at the percent of hospital beds available, New York City and Long Island have the lowest percent available at the moment. And that's concerning. But remember, it's the number that it has to hit, right, is that 90% capacity. I wanted to include this as a historical comparison. So I did Long Island because Long Island currently has fewer hospitals. The percentage is fewer than New York City. But you look at this, I did the 10% thing there. Even in the worst of it, the lowest it got was 13% of the hospital. There was still 13% of the beds available in Long Island. This 25% increase in capacity will certainly help. But again, it's that growth rate, and we don't have that number yet. And it was a lot more math than I had time to do this morning to try to calculate that out. Turning on to school updates, this is a big change. We finally have the guidance document. I'll run through it really quickly. Schools in orange and red zones no longer required to shut down or close in-person instruction. Instead, in orange zones, 20% of the in-person students, staff, and faculty must be tested over a 1-month period. That breaks down in the guidance. They say you have to test 10% on a biweekly basis. It needs to be balanced. You can't just test 15% in the beginning of the month and then only test 5 at the end of it. Same thing in a red zone, except the percentages are different. 30% in the beginning, 30% overall throughout the month. So you have to do 15% biweekly. Schools have to close, though, in the orange and red zones if one of two things happens. Your random sampling generates more than or equal to or more than 9 cases, 9 or more, or for a sample size, and this is where it gets really fun, if you're taking over 300 weekly tests and you have a positivity rate in New York City that is greater than or equal to 2%, which breaks down into 6 cases approximately per testing cycle, or in other districts everywhere else outside of New York City, you have approximately 9 cases, you have to then close down. So that is my really quick overview of that. If you do have questions on that document, please reach out to us. One other question that was brought up in the past few webinars, I've been getting a lot of questions on this. The Department of Health has regulations out that are about non-essential gatherings. This is from 10 NYCRR section 66-3.3. In it, it's about non-essential gatherings related to COVID. It says, obviously it says that you can't have more than 10 people at a gathering. But the people get stuck on that line. They don't read the next line that says, this restriction may be modified by any executive order. These executive orders all modify that, that regulation. The executive orders at this point are what we need to follow regarding gatherings. And with that, that's my really quick presentation. I'm done.
Katie, thank you. And thanks everyone for being with us. Apologize for running over a little bit today, but it is our goal to get you the most current content. Please don't hesitate to reach out to us with questions, or if you have needs. Stay safe, everybody, and we'll see you back here next week.